Hello everyone, I'm Dr. Sykalo from Northeast Georgia Medical Center, and I worked on this project with Dr. Adigopula from the Georgia Heart Institute. We have a case of a presumed stroke recrudescence that delayed diagnosis of statin-induced myonecrosis. Statins are used for prevention of cardiovascular disease and work by lowering serum cholesterol levels. These medications are generally well tolerated, but 0.1% of patients develop severe myonecrosis leading to rhabdomyolysis, which is the most severe form of statin-associated muscle symptoms, known as SAMS. Here, we present a case of a patient whose presentation was not recognized as SAMS due to previous stroke, leading to a delay in proper management. Our objectives are that statins must be discontinued for a trial period in any patient who developed muscle pain or weakness. Clinicians should use the Statin Myalgia Clinical Index for timely recognition of statin-induced myalgias and avoid progression to rhabdomyolysis, and we must all maintain a high clinical index of suspicion when using statins for secondary prevention, as myalgias can present as stroke recrudescence. Our case is that of a 56-year-old female with a past medical history of stroke 2.5 years prior to admission. At the time, the patient had presented with right-sided ptosis and left-sided weakness. She was started on aspirin 81 mg and atorvastatin 80 mg and discharged to a rehabilitation facility. Her left-sided residual weakness returned nearly to baseline, and she was able to exercise regularly. However, 2.5 years after the stroke, the patient began experiencing increased fatigue that progressed to left leg weakness. This was initially presumed to be stroke recrudescence. The statin dose was decreased, but weakness progressed to include the right thigh and distal upper extremities spreading proximally. She tested negative for myasthenia gravis and amyotrophic lateral sclerosis. Her CK was found to be 9,000, after which atorvastatin was discontinued and she was admitted to the hospital for IV hydration. For the following months, her CK ranged from 7 to 10,000, and she underwent muscle biopsy showing active myopathy. Testing was positive for ANA and HMG-CR antibody, confirming SAMS. Thus, she was started on a steroid taper and methotrexate. The patient, in her own words, describes the experience as frustrating and states she hopes to raise awareness so that others are recognized earlier and do not have to suffer like I did. From the myositis, the patient developed daily pain which led her to cry even when brushing her hair. Under imaging, you can see the scattered necrotic and regenerating fibers indicating an active myopathy. The arrow shows the myofibril degeneration seen on biopsy. Additionally, we have included the proposed Statin Myalgia Clinical Index score to be used for scoring of suspected SAMS. The flowchart shows a SAMS management algorithm that is based on the Cardiovascular Therapeutic Guidelines and the European Society of Cardiology and European Atherosclerosis Society Guidelines for the Management of Dyslipidemia. The available data suggests the statin treatment of patients with elevated LFTs up to 3 times the upper limit of normal appears safe and does not lead to severe liver disease. However, if ALT is elevated greater than 3 times the upper limit of normal, it is treated the same way as elevated CK and statins must be stopped. In general, the recommendation for suspected SAMS is to calculate a SAMS clinical index, which determines the likelihood that muscle symptoms are due to statin use. In patients on statins with unexplained myalgias, it is crucial to completely stop the medication for at least 2 to 4 weeks, even if a more likely diagnosis exists. In terms of treatment, anti-HMG-CR myopathy with normal strength is common, and a corticosteroid-free induction strategy should be considered. In patients with proximal weakness, induction with steroids, IVIG, and a corticosteroid-sparing immunosuppressant is useful and may allow accelerated steroid tapering. Targeting early remission increases the efficacy of a corticosteroid-sparing immunosuppressant regimen in maintaining remission. In conclusion, our patient is doing well and attending physical therapy to achieve her previous baseline. She was treated with a year-long course of a steroid taper along with methotrexate based on the previously stated European Neuromuscular Center treatment recommendations. Her CK has been trended and currently has improved to less than 1,000 in a span of a year. In patients on statins with unexplained myalgias, we want to recommend everyone to calculate the SAMS clinical index score and to recommend stopping statins for a minimum of 2 to 4 weeks, even if a more likely diagnosis exists. Thank you for your attention.